Good morning. Can everybody hear me?
Yes, we can. I can.
Yes.
Okay. All righty. Just wanted to make sure that my audio was working. Sometimes that is a challenge.
Good morning, everyone. This is Kelly Sheets. I am with the Department for Medicaid Services, and I will be your host for today's meeting. I have 11 o'clock, and it looks like we do have a quorum. I have 4 members on. So I would like to remind, if you are a TAC member, in order to comply with the open meeting laws, when you're voting, please make sure your camera is turned on. Thank you very much.
Okay.
Or what is turned on?
Your camera.
Okay.
And with that, like I said, we do have a quorum, so I'm going to turn it over to you guys.
All right. I'm going to skip the introductions unless somebody would like for everyone to be introduced. You can see on the side who is on the call. We'll move forward to the approval of the June 22nd minutes. They were mailed out or sent out to the TAC. Are there any additions, deletions, corrections, anything that we need to do with the minutes?
Terry, just one minor, I did notice on the top of page 23 that it was stated that the SPA would be, I think, approved for the next 10 years. I think it should be the next 2 years. Small change.
We'll have that change reflected in the minutes. Anything else? Do I hear a motion to approve them as amended?
So moved.
Motion by Jay, a second.
Approved.
I believe that was Adam. All in favor, aye.
Aye.
Aye. Any opposed? Hearing none, the minutes are approved. Go into the agenda. The first thing on the agenda, obviously, is the Medicaid unwinding. I know our association has sent out a lot of information regarding the unwinding. The billing work group met, I believe, last week, and the information was shared at that point in time by the commissioner, and we have sent out as much information as possible. Was just kind of hoping that we would just have a brief outline as to timeframes as that are happening. If somebody'd like to chime in on that, if not, I'll tell you what the timeframes as we understand them. Is anyone prepared to just give us a brief overview of the unwinding?
Sure. Hi, good morning. This is Veronica Judy Cecil, Deputy Commissioner for Medicaid.
Thanks, Veronica.
Hi, I wasn't sure if you wanted me to do the presentation for the folks that were, part of that billing work group or not. So I'm prepared to, but it is a little longer. So at your pleasure, if you want me just to speak to it and not do the presentation, happy to do that too.
I'm comfortable with you just kind of giving us a summary and not going through the entire presentation.
Sure, no problem. So right now, we are fast approaching the start of our unwind. The Consolidated Appropriations Act of 2023 signed and put into law in December is requiring states to restart normal eligibility and enrollment processing, as well as do a redetermination of everyone that has been under the continuous coverage requirement throughout the public health emergency. The continuous coverage ends on March 31st, and so that's coming up. And each state is taking a little bit of different approach of how they're going to unwind that renewal process. So for Kentucky, the first renewals will take place for those who have a renewal date of May 31st, 2023. So those folks that have a renewal for May will start to receive notifications April 1st. And so notices will go out to anyone that we cannot do what's called a passive or ex parte renewal. Our system will automatically on April 1st try to renew everyone. And that includes the entire population, even those that are that we do a resource determination for. So it will attempt to go out and hit all of the databases that we have available to us and verify people's information. If we're unable to verify, then they'll drop to what we call a more active redetermination, and they'll have to take steps. For the ones that we're able to verify that they meet eligibility, they'll just automatically be renewed. And so they won't have to take any additional action. It's really great for them. They'll get a notice telling them they've been renewed, nothing further is needed. So we're going to be focusing on those individuals that we can't do that passive or ex parte renewal for. We believe that's about 20% of our population. So thankfully it's a smaller number than if we were having to do that for everyone. But I do want to also make sure everyone understands that we're doing this over 12 months. So we have a little over 900 cases, and that's for, over 1.5 million people that we'll be doing redeterminations for over the course of 12 months. So from May 2023 to April 2024. So not everybody is going to drop off in May if we can't renew them. They're spread over, or the case mix is spread over the entire 12 months. We are we're going to provide a lot of supports to our members, and we are asking providers to help with that. But we'll be sending an email and or text message if we have both of those modalities of communication on our system, and they'll get a notice letting them know when their renewal is and that it's coming up. That'll be about 90 days before their end date. They'll get another notice about 15 days before their end date if they need to take action and we haven't heard from them. So for example, if we've sent a request for information and that hasn't been responded to, that person will get a notice and say, we haven't heard from you. We need to. The end of the month is coming and you're going to be discontinued. We do plan a lot of robust outreach through phone calling. So our managed care organizations are going to reach out to their population. And then we have a plan for the fee-for-service population to call individuals that are, as we approach the end of the month, that haven't taken action. We're going to try to reach out to them to see, perhaps maybe they're no longer eligible and they know it, so they're not taking any action, but we want to make sure if they are likely still eligible that they do what they need to do. If there's anybody pending a redetermination at the end of the month, they will continue. We will not end date somebody based on a worker action, a needed worker action. So those folks should not be discontinued. We'll keep them in. And if somebody sends us documentation about 90 days after their end date and they're able to provide us what we need and we can determine them eligible, we will reinstate them back with no gap in coverage. So those are some of the ways that we're going to support folks. There are some stakeholder meetings coming up, and they are on our website and on our social media where you can register. There's March 16th, March 22nd, and March 27th. Certainly if you can't participate in any of those, we're going to be recording and posting that online on our website, which is medicaidunwinding.ky.gov, and I'll put that in the chat. The biggest thing we're just asking people to do is to follow our social media, because that's going to be our conduit for quick and effective communication about what's happening, especially if we're finding a trend or need to change something, that'll be the best way for us to communicate that out. And then we'll be keeping our website updated with reports where you can monitor how the renewal process is going, how many have been renewed, how many have been terminated, so that we're keeping an eye on the population and seeing, who's impacted by it. So I think that's a lot to take in on the renewals. And then just one other thing to note. So the White House did announce the end of the public health emergency. That's May 11th. So a lot of the flexibilities we've been under, several of those will end on May 11th. Several of those impact our nursing facilities. Right now, we'll return to the 50% bed reserve reimbursement. We'll no longer be able to do the 270-day per diem add-on for COVID. And we'll return to 14-day nursing facility bed hold when after May 11th, because that's our flexibilities end with that. So that again is just a really kind of high level information. Happy to take
Well,
questions.
And you did a really nice job with the billing work group the other day. And I anticipate that these 3 provider sessions that are coming up will have similar information shared. Just a couple of quick questions that I know have been asked of me. If somebody were to start contract COVID and start a COVID stay, say on the 8th or 9th of May, I'm assuming May the 11th is a hard cutoff that they would not be able to continue that stay, correct?
So the additional per diem would no longer be available. Come May 12th.
And that was my understanding, but I wanted to verify.
Yep.
And then I know you said that emails and texts would be sent out to the recipient or their guardian, et cetera, and then follow-ups with phone calls and all. Facility notifications. I think in your presentation, you indicated that there would be a way that facilities would know which of their residents are in the cycle so that they can assist those families in getting that information over to you. Can you talk about that real quick?
Absolutely. Thank you for bringing that up. I did leave that out. So we are right now working on configuring clocks for you all to be able to pull a report specific to your facility that has the that has the members redetermination date on it. So you'll be able to track when somebody may potentially discontinue. And we're hoping providers, and I didn't really elaborate on this, but we're hoping providers, when they are interacting with a Medicaid member, that they are taking that additional step to check Kentucky Health Net or clocks to see when their renewal date is, and just make sure they understand. The other piece to that is we do have on our website some flyers you all could pull down and post, just that talks about unwinding. Right now, and you all could do the same, is encourage members to keep their Medicaid contact information up to date. We just want to be able to reach them. And, we do have trouble with return mail, and, people's phone numbers change, and just having at all times the most up-to-date contact information is going to be the best way for us to try to all help that member through the process.
Are there any more questions for Veronica?
Well,
Okay.
so let me mention about the clocks report. So we're finalizing the work on that. We do plan to reach out to all the facilities and provide training. We'll post the training if you can't attend when we hold the webinar, and we'll help facilities understand how to go through that process.
Excellent.
So that's coming up in April.
Hi, this is Holly with Anthem, Kentucky. And I was wondering, you mentioned the Kentucky Health Net. Did you say that will have the members' eligibility renewal date on it? Is that something that we can check there for the members?
Yeah, Holly, and let me mention, so we've reallocated our caseload. And so right now, if you go in and check Kentucky Health Net, the date you see in there for somebody isn't accurate. So we are implementing our redistribution on March 21st. And so come March 25th, the date that you'll see in Kentucky Health Net will be updated with the accurate redetermination date. Because, we've been keeping some people, we just keep doing what's called a special circumstance, and we just keep moving them month to month. So you're going to see several people in there probably show April, and that's not true because we're not even starting our renewals till May for the May renewal date. So thanks for that question, Holly. To clarify, at the end of March, Kentucky Health Net will reflect what somebody's redetermination date is.
Thank you so much.
Yep.
And Veronica, one last question. Did I remember from the billing work group the other day that starting April 1, any new applications to Medicaid would be under the old process?
Pre-public health emergency. Yep, we're returning to our original rules.
Okay. Any other questions?
Yeah, Terry, this is Wayne. Just one other, and Deputy Commissioner, thanks for a great presentation to the billing worker group. Really appreciate that. It was very, very informative. And just so you know, we have yesterday sent out our member communication, the KHCF Connections, which included the stakeholder meeting dates, as well as the Medicaid website address, as well as all of the social media options that are out there. So I think our members have all that information handy. But one question that I wanted to ask, and this was one of the questions that I know you are in possession of. We sent a number of questions to you for a response, but one of the questions that was asked was the nursing facility credit balances. Individuals, because patient liability was not able to be adjusted at all, Social Security increases, et cetera, and it increased patient payments were made. What will happen to patients that had patient liability changes that were not entered into the system that result in credit balances in their account? And if, for example, they were on a deviation that should have ended, the caseworker wouldn't begin the patient liability process again in the system, which results in a credit balance. Will those individuals have to spend down, go out, make a complete new application, come back in, or had you mentioned reference that in our billing work group?
Yeah, I'm not an eligibility person. So we are trying to formulate a clear response on that. We did get approval from CMS to extend the disregard for excess resources for the unwinding period, for the 12-month unwinding period. And so we're trying to put that into language that you all understand, so that you have that available to you. We're just verifying all that with our eligibility folks to make sure we're all on the same page. But we did ask for that to extend that long-term care disregard, and so in my language, what that means is that folks would be able to pay that down and not spend that down and not have that affect their eligibility during the unwinding period.
Okay, perfect. I appreciate that clarification. That will be that was one of the questions I think that came up multiple times. So thank you.
Any other questions? Deputy Commissioner, we appreciate it.
You're so welcome.
Great update. Great update. Moving into the next section, the section G crosswalk. I know that the current support for the RUG 3 system ends on 9/30. I know that our association is doing some work on a potential or proposed crosswalk at this point in time. We're still testing at this point. Just wanted to get an update on where we were. I know there was some mention at the last meeting about freezing the CMIs and just checking to see if there was any update at this point in time on the crosswalk and any work that might be being done on the cabinet's part.
So I'll try to take that one.
Thank
a little
you,
bit.
Steve.
So, yeah, Steve Bechtel, CFO for Medicaid, for those who don't know me. We, as you stated, the MDS rugs goes through September, or I think it was October, and no, it's
Yes.
September.
September
September 30 is
2023.
the last day on the MDS.
And so that period, that last period will be used to develop your January through March rates.
Correct.
And so our intention, so that we can avoid those optional state assessments, those OSAs, our intention is to freeze those rates for the April through June. And then on July 1st, we will be transitioning to PDPM.
Okay.
Now, as far as your question as to the crosswalk, we're still gathering data as
Okay.
of right now to model the PDPM. We understand that there will need to be some decisions to be made on CMI weights for the PDPM categories and things. Those decisions will probably not be made until we have time to gather all the data. Most likely that won't take place until sometime this fall, around August. And then around October, we'll be working on a UPL analysis and things. So it's a lot of moving parts that we're working on to try to transition to the PDPM process. So, but we will, and I have been talking with Wayne Johnson and Jay Trumbo about this, the crosswalk of the section G, and they provided me some ideas, and so we're working with Myers and Stauffer to see what makes the most sense. So don't have anything really definite to tell you today or any update, but those are the ongoing information that I've got for you right now.
So basically the plan would be to freeze it for the 1 quarter, and between now and the end of the year, have something in place where January 1, we would start tracking under PDPM and set the July rates from that first quarter. So January 1 through March 31 would set those July rates. So I guess the hope at this point in time is to have something in place by January 1 to start tracking it under the new system.
Correct. And Beth, I've asked Beth Vale, a lot of y'all know who she is, from Myers and Stauffer, to be on this call to hold me to to correct me if I'm saying anything wrong. But
Everything's
Beth,
good, Steve.
I believe his statement was correct, but you correct me if I'm.
Yeah, I guess I just wanted to kind of jump in a little bit. I've seen a little bit of the Section G kind of, we all know Section G goes away October 1st. But keep in mind, back in October of 2020, Section GG and all the PDPM items were put on all the comprehensive and quarterly assessments, your OBRA assessments. So the data's out there in terms of determining what the PDPM values are and what the trends are. And so everything will be good for a transition to PDPM effective July 1, using that first quarter 2024 assessment information. Because, an assessment that's active January 1 could actually be going back not only into October,
True.
but even September, the other quarter, because they can be active for an entire quarter.
True.
Before the other ones do. I guess something to keep in mind is, right now the rug payments are on the rug 334 grouper.
Right.
And at one point, CMS moved to rug 4, which your Medicare payments were based off of until PDPM. And, that transition didn't happen here in Kentucky Medicaid. And so when the PDPM nursing groups were announced, they basically took those existing 60 some rug 4 groupers and collapsed it to the 25. removing all the rehabilitation categories. And so we're left with the 25 nursing categories to establish a case mix index. You know, and that's where some of that analysis is going on right now. I guess, was there anything to bring up right now about like this potential crosswalk and how that would work with Section G going away and just, you know, adopting the 25 nursing groups under PDPM? Or
I think one of our biggest concerns is the rehab categories, which,
Sure.
you know, the 25 nursings don't capture the rehab categories. So as you all are working toward developing yours, are the rehab categories being taken into play?
Well, as when CMS developed the PDPM payment groups, you know, instead of counting the minutes and the days of therapy, it went more to, you know, diagnosis codes, what was the prior hospitalization for, to capture the needs of the residents. So the current methodology under the Medicare system using PDPM is no longer using rehabilitation minutes and days and those things. It's more based on the resident's diagnosis and maybe why they are entered the nursing home. You know, did they get a knee replaced or hip replaced? What's that, you know, clinical picture looking like that might cause them to go into therapy and need those extra resources. You know, if Medicare has, you know, the various categories under PDPM, I think it's the 6, and then, you know, I think the thinking is that Medicaid would adopt, you know, the nursing category to closely correspond to what's going on today. But yeah, there's certainly some considerations to be made.
So Terry, I think, you know, our next step is, you know, we'll work with you guys. If you have any thoughts or any suggestions, like you said, you know, let us know, and then we'll work with you all to see what we can do to make sure that we correctly account for all of that.
Yeah, I mean, I was going to say, we've got an MDS task force that's, you know, got all of our clinical folks in it. And, you know, I would definitely want them to be participating with the folks from Myers and Stauffer in the cabinet to develop the crosswalk as it's being, you know, moved forward for that January 1 implementation.
Okay.
All right. Appreciate it.
So
Anything else from?
Well, let me make sure, because I'm not sure who that is or how to get them involved, but I guess Wayne, you'll help me figure that out.
Yes.
Okay.
Yeah, we will.
All right.
I think Wayne is our association representative with that MDS task force, since obviously it does drive our rates. You know, it's very much part of our reimbursement committee process.
So, and Wayne has been the one who I've been working with the most on all of this. So I'm assuming, Wayne, that you'll be bringing in everybody that needs to be brought in on your end.
Yes, correct.
All right. Okay.
Thank you, Steve.
Thank
Thanks,
you.
Beth.
Oh, you're welcome.
All right. Wayne, I'm going to toss the next one off to you. You've been working with it in the background on the guardianship inaccessible assets update. Go ahead.
Okay. Wayne Johnson again with the association. We had a meeting with the Department for Aging and Independent Living, Commissioner Eldridge, back early February. And this issue we've raised this issue with the nursing facility TAC on a couple of occasions. And we were bringing it back up with Commissioner Eldridge. And she, in that meeting, indicated she would follow up with the Department for Medicaid Services. I don't know if that meant Commissioner Lee or Deputy Commissioner Cecil, but to determine where our request is on treating guardianship residents differently when assets are deemed and what are referred to as excluded resources due to being inaccessible. So our understanding is excluded resources are assets that aren't counted in the Medicaid eligibility determination because they are inaccessible primarily. Some resources are excluded for a limited amount of time, while others may be excluded entirely. We're just inquiring again where this stands with the Department for Medicaid Services as well as the Department for Aging and Independent Living, because our guardianship residents are truly incapacitated individuals. And we are, as we have been, especially over the past couple of years, been having issues with just getting the needed documentation to prove that they are Medicaid eligible. So it's just really more of an inquiry to where this currently stands. And I don't know if Deputy Commissioner Cecil could speak to this or who, but we're just wanting to find out.
Deputy Commissioner Cecil had to drop for another meeting. Is there anyone else on from Medicaid who could speak to this?
Hey Kelly, it's Pam. I can't speak to it, but I will take it back and find out. I have not, Commissioner Elrich has not spoken with me, or I've not been in any meetings, but that doesn't mean that hasn't happened. So let me, I'll take that back and find out.
I appreciate that. Anything else there?
That's all I have, Terry.
All right, we have a guest today. Dr. Baber is with us for the polypharmacy report and for the report on hospital medications upon discharge. And if I can't see everyone's name on the little panel to the side. I'm assuming Dr. Baber's on, and if so, I will turn the meeting over to him.
Yes, Terry, I am on. And along with me is Dr. Rena Van Gelder. She is Deputy Director for Pharmacy Services. So we're going to make a short presentation. The whole idea was we wanted to get your input that regarding our polypharmacy initiative, and wanted to have our collective wisdom guide us in a way that some of the hurdles which we have faced, and wanted to share our journey. I saw Betsy's name is on the callers, and KCFS with Betsy and my other friends, they've been part of these discussions and they've been very helpful to us. So Dr. Van Gelder, would you kindly make our quick short presentation?
Hi, is it okay if I share my screen?
Yes, I've made you co-host.
Thank you. Please let me know if you are able to see the presentation.
I can see it.
All righty. So good afternoon, everyone. We're here to talk about the Kentucky Medicaid Polypharmacy Initiative and just kind of where we are and where we've been with this project and some of the hurdles that we faced. So just as a friendly reminder, the short-term goal of this is to gain insight from stakeholders on the successes and challenges of deprescribing medication with structured interviews. So we have developed a series of questions. We are trying to outreach to our healthcare team that would be most actively involved to get different vantage points from the medical director, the nursing director, or assistant director of nursing, mid-level practitioners that may be involved, and the consultant pharmacist. Our long-term goal really here is to establish a collaboration, a free statewide resource for LTC facilities and staff to promote deprescribing among our Kentuckians. So this is solely a collaborative partnership to improve the lives of our Kentuckians residing in LTCs. We are not looking to develop any type of penalizing policy. So just a summary of the information being collected, just standard processes, just to kind of give you an update on what we're trying to collect, any type of standard deprescribing processes that may exist in your facility, successes and challenges that staff experiences with deprescribing efforts, the clinical benefit and how that's weighed, especially when adding to treat medications of another side effect, adding on a medication that may treat a side effect, as well as evaluating the clinical need for adding back any type of therapy after discontinuation, any type of collaborative deprescribing involving specialists or other providers external to the facility. And we know we have a racial disparities initiative here within the department. So just any type of, racial inequities that we might be seeing that we can help address with medication management in the nursing home. That could be with the members or with families. And any idea on how DMS can further this collaborative effort. So our current progress, we obtained IRB approval both with UK, University of Kentucky, and CHFS in October of 22. We defined our study population using the OIG license directory and those classified as a nursing facility. We did electronic outreach by public facing portals or email addresses with kind of a template letter. And I needed to update the statistic. We have actually contacted 25% of the facilities that qualify as our inclusion criteria without success of participation. So we're coming into some hurdles. Some issues that we've heard about, maybe like the legal structure that may, for some of the larger nursing homes, they might not be as easy. There's going to be levels that need to have this project evaluated. And I know Dr. Bobber is working internally with his nursing home signature to try to see if we can engage them. We're unable to directly contact specific persons of interest without public facing information. This is the concept of cold calling. It's just an IRB kind of regulation. And we do have limited manpower for study recruitment. So it is just Dr. Bobber and I primarily doing these outreaches. This is something that we're doing in addition to other tasks within our scope of our job. So we're trying to figure out how we can be efficient and also help you all as well. So we do want to help you all with these deprescribing efforts. And if you have any suggestions on ideas for modifying our recruitment efforts, we're certainly open to that. And another idea we had potentially engaged in was possibly transitioning this study design to an online survey. Would that be more easy and effective? So I'd just kind of like to open the floor to anyone who would like to provide us with some feedback. So thank you all very much.
Wayne, based on the information, I guess Wayne or Betsy, I see Betsy there now that I can see everyone. I mean, is this information something that our survey and regulatory committee could take into consideration, review, and possibly, make recommendations or, see how facilities can participate? I mean, I can understand from the legal aspect with the facilities, some of the roadblocks that they're running into, and I'm not sure I have any other input other than, is there a committee within our organization that could take a look at it and see if there's ways that we could, help or encourage our facilities to participate?
Yeah, my understanding, Terry, is Lisa Biddlepuffer has communicated in multiple times with Dr. Babar, but yeah, that is something that I think is ongoing, and I believe it has been raised previously within the regulatory committee.
Okay.
But I also wanted to bring up one of the things when we were talking to Dr. Babar about including this, the polypharmacy agenda topic on the nursing facility TAC meeting, as one of the agenda items is we also ask that time be given to address the prevalence of hospital medications upon discharge to nursing facility providers and how the Department for Medicaid Services might be able to assist in communicating this issue to acute care providers, simply due to the fact that, polypharmacy issue, the prevalence is many times due to, acute care discharges. So I wanted to just raise that issue. I don't know if now is the proper time or not, but did want to make sure that we address that as well.
Okay.
Yes, so this is this question is part of the agenda, and so Wayne, first to your point, I am with DMS as a consultant, and then I have my own clinical practice. So what I have seen out there that there is within the facilities that we don't have an environment of collaboration, that there is always fear and there are concerns. When I thought about polypharmacy, I was hoping that we will bring a sense of collaboration, that it's not we are putting another regulation out there, that we all together, because our goal is common to take care of elders. So we will come up with that. But unfortunately, our healthcare system is broken, and we are part of that broken system. I can understand the concern of facilities, because especially in our Commonwealth, that we are really in an environment there, litigations and frivolous lawsuits are so common here that we don't want to leave any room, that because the facilities barely they have a room to breathe right now. Within Signature, I know Signature is not part of KHCF or Leading Age, but they had their own research committee, and I have approached to their compliance department, and they have forwarded my request to their research committee, and still waiting for them. I had also approached to Trilogy and forwarded to them. In this discussion, the only if you guys get chance to look at our questions, that these are just, it is anonymous surveys. These questions are just very benign questions, just to the point that try to bring the attention of our stakeholders or leaders of our facilities to this issue, and then for us to understand that how can we be helpful in facilitating that. So I don't know if the survey committee or if regulation committee, it's very difficult, but I don't know how can we gain this trust. So if you guys can help us out, I'll really appreciate that. And I wholeheartedly agree that polypharmacy is not just a LTC issue. Polypharmacy is a huge issue, and there are so many pieces to this puzzle, which starts from patient's primary care physician, goes to the hospital providers, and then to the LTC providers. And then patients and families also share some of their burden, that some of them are very happy to and trigger happy to have medicines initiated and push this cycle. Hospitals, COVID pandemic stopped the efforts, but we were in Louisville, we were actively meeting with, through CAMDA, Kentucky Medical Director Associations, we had an active engagement within the hospital, with the hospitals for med reconciliation forms on discharge, and on which our main issue was, and the hospital actually, they are well oriented. COVID stopped our progress, but medicines like, let's see, Lovinox, every DVD prophylaxis they are starting, and a lot of time they don't stop that. GI prophylaxis, Protonics, they don't stop that. A lot of time they start antipsychotic, which is a big battle for us in the facilities, and they start that medicine, they use it as PR, and they don't stop it, and put us in a bind there. So I think if you guys can, being new to DMS, if the TAC can guide us, that how DMS can assist proactively in that, we reaching out to the hospitals from the platform of DMS, we will be open to that, and I would definitely try my best to seeking their attention to assist us in reducing polypharmacy, because one extra medicine leads to another medicine, and then polypharmacy in the end leads to increased hospitalizations at times. So their mutual interest is aligned with our common interest as well. Thank you.
Thank you.
And Terry, do you mind if I
Please,
just
Betsy.
respond? And I apologize. I was double booked, so I had Lisa Biddlepepper cover another meeting for me at this time. So because she does have the information about where we are on this. I do know she brought it before the Survey and Regulatory Committee. And Dr. Barber, I know you understand the issues that our skilled nursing facilities deal with, and I wholeheartedly agree that collaboration should happen. But unfortunately, we always feel like we have a target on our backs and not the support, unfortunately, that we deserve from the government. So I will promise I'll touch base with Lisa and see where we are. We are having a board meeting next Thursday. So I will try to get that raised as well to see collectively what our board thinks about this issue. But unfortunately, I think the times that we've raised it, the response we get is, well, what about the hospitals? Because again, we tend to have a target on our back, which is unfortunate and reduces the ability to collaborate. But I promise you that I will follow up on this issue, and we will attempt to get a response and work with you on this important matter.
Thank you so much, Betsy. You have been always very helpful. And Lisa, you've been part of our meetings with us, and I truly appreciate your servant leadership. I will talk to Commissioner Lee and Deputy Commissioner Veronica, and I will try to see that if there's the platform where we can engage hospitals on this issue, we will definitely do that. Thank you so much.
Thank you. All right. Are there any other issues that need to come before the TAC today? Hearing none, our next meeting is scheduled for June the 14th. Notices, I think, have already been sent out, or at least the links. And if there's no other issues or no other discussion, we will stand adjourned. Thank you for attending.
Thank you.